Okay, let's get started. So think about where we've been in this course so far. All right, we've talked about determining the patient's ABO. We've talked about solving discrepancies. Okay, so we're going to talk about two other tests today in lecture 5 and 6. We're going to talk about the direct antiglobulin test, also known as the DAT, which we have talked about in hematology. You guys remember that. So we're actually going to dive in and discuss exactly what the DAT does. And then in lecture 6, we're going to focus on the indirect antiglobulin test, the IAT. Okay, so we're going to differentiate between the DAT and the IAT. You guys have to understand that both the DAT and the IAT use the same reagent. Okay, we are going to be using what we call anti-human globulin, or AHG. Okay, both the DAT and the IAT use the same reagent, but we are looking at different patient samples. Okay, so the DAT, keyword there is direct. We're looking at what has attached to the red cells inside the patient body. What is directly attached to those red cells? Okay, that's your DAT. The IAT, the indirect, we're testing patient plasma. We are seeing if the patient has any unexpected antibodies. And you guys remember what this anti-human globulin reagent does. Think about the size of that IgG molecule that it only has 2 binding sites, very small. It is not easily able to overcome the zeta potential of the cells. Okay, so we are not able to visualize when an IgG antibody has attached to the cells. So that AHG reagent kind of serves as a, and I'm going to demonstrate this, it will bind to the antibody, therefore bringing the cells together so we can visualize that agglutination. Okay, that's what the AHG does. And you'll see that as we go through these lectures. All right, so the antiglobulin test, 2 different tests, but they use the same reagent. This is very important because when you think about what's going on inside your patient's body, if they have any type of intravascular hemolysis going on, we want to know what's causing that intravascular or even extravascular hemolysis. Are those cells being taken out by the spleen because there is an antibody attached to those red cells? And if you think about that, in hematology, we talked about hereditary spherocytosis, and we also talked about autoimmune hemolytic anemia, where the antibody could attach to the red cells, and in the spleen is either going to try to pit it, where it's going to try to pinch off that foreign antibody, or it's going to completely destroy the cell. Okay, and so if that's going on inside the patient's body, we want to know what's coating patient cells. So in a DAT, the anti-human globulin test will let us know, is it due to an IgG antibody or is it due to complement? Okay. So there's key things about the DAT and the IAT that you need to know. The DAT detects antibodies or complement that has attached to your patient red cells in vivo. Okay, that is occurring inside the patient's body. That has already occurred. Versus the IAT, we are looking for unexpected antibodies, and we are forcing the patient's antibody to react with our commercial reagent cells. Okay, so we're testing in the IAT, we're using patient plasma. And we will talk about the specifics of the IAT in lecture 6. We're going to concentrate on the DAT in this lecture. And again, the reason for this, the purpose of your antiglobulin test, we want to know, we want to identify any unexpected antibodies. Now, when I say unexpected antibodies, what I'm referring to, think about our ABO antibodies that we have talked about. And remember Landsteiner's rule, if you lack the antigen, you can build the antibody. ABO antibodies, such as our anti-A, our anti-B, those are expected. Those are naturally occurring, okay? So if you're type A, you have the A antigen on your red cells, you have anti-B in your plasma. That's expected. We expect to have that. Unexpected antibodies are IgG antibodies to other red cell antigens, such as if you had anti-big E, or anti-little e, or big C, or little c, Duffy A, Duffy B. Those are unexpected red cell antigens that are antibodies they are of IgG classification, meaning that they had to be produced from a previous exposure, right? Either a transfusion or for females, a pregnancy. Okay, those are the only ways that you can build those IgG unexpected antibodies. Okay, and the reason your antiglobulin test is so important, like I mentioned, because the IgG antibodies are so small, just after centrifugation at initial spin, we are unable to see that agglutination. The antibody might have attached to the red cell, but we can't see it because it's only sensitized. Okay, it's only that first step of agglutination. Okay, for us to be able to see that antibody attached to the antigen, we need enhancement, and we need AHG to further allow for that agglutination, all right, to be visible. Does that make sense to everybody? Okay. All right, so how this works is you have your IgG molecule. The IgG molecule is going to attach to the red cell on your antigen in the FAB portion. Okay, so if you think about your IgG molecule in the shape of a Y, where your two heavy chains are, your two light chains are, your FAB portion, so your IgG molecule has two binding sites. All right, so that's where it's going to attach to the red cell. And remember that cell's zeta potential and the size of your IgG molecule, that antibody is attached to the red cell. However, we cannot visualize that, okay? And that's why if that happens in vivo, the patient could be experiencing extravascular hemolysis. The spleen is going to take out those cells. Okay, so here's an example. I took this from your textbook. So you have a, here's your IgG antibody. You mix it with your red cells. The IgG antibody, again, is going to attach to your red cells. Right, so here's your FAB portion. Right, notice how these cells are not agglutinating. They're not agglutinating, all right? So that antibody is attached, but there's no visual agglutination, okay? And I'm going to show you what AHG does. You think about why this is so important. The goal, ultimately, of blood bank or transfusion medicine is to provide products that are safe for our patients, right? We want to replace what they're lacking. In the case of red cells, we're maybe giving them oxygen carrying capabilities. Maybe if they're having a coagulation disorder, we're replacing factors for them. We want to make sure that that product we give them is not going to be destroyed. So that's why compatibility is a huge concern in blood bank, okay, in identifying any antibodies. If we identify an antibody, we want to make sure that we find, for red cells, antigen negative to the antibody that they built, okay? Especially if they have a positive DAT, that means that they already have an antibody that is coding the red cells, or it could be complement as well, okay? Again, remember, you guys need to remember this. The only way a patient can build a IgG antibody is through previous transfusion, exposure to donor antigens that they are negative for. Okay, remember Landsteiner's rule, if you lack the antigen, you can build the antibody. So if you are ever transfused red cells and that donor is positive for an antigen that you are negative for, your body's going to recognize that red cell antigen as foreign, and you could potentially build an antibody to it, okay? And then females, if you've ever had a pregnancy, if the baby is antigen positive for an antigen that mom is negative for, during the fetal maternal blood exchange, mom could be exposed to that antigen, she could build an antibody. Not a concern for her previous pregnancy, okay? Unless it's an ABO. If mom is O and baby's A, then that's ABO, and that can cause immediate hemolytic disease of the newborn. But let's say anti-D or any other IgG antibody, she's going to build that antibody. It could affect future pregnancies for her because that antibody could attack baby cells, okay? And like I mentioned, our ABO antibodies are naturally occurring. We expect those, right? However, to have another IgG antibody in your circulation, that is not a normal circumstance. Why it's very important for blood bank to identify those. So what's going to happen is the patient might have a IgG antibody that has attached to the red cell antigen, but we don't know that because that's only sensitization, right? We might not be able to visually see that, right? And an example of that would be hemolytic disease of the newborn, in which anti-D is present. So mom's anti-D, if baby is Rh positive, anti-D will attach to the D antigen on baby red cells. Mom's spleen is going to take those cells out. Baby's going to be in respiratory distress. It could end up in a early delivery or a intrauterine transfusion. The thing you have to understand is, if this is occurring, if mom's antibody is attaching to baby cells, anti-D is an IgG antibody. It's very antigenic. If it's attached to the red cells, we need to know that. But because it's so small, we won't be able to visualize that agglutination. So we need a way that we can bring those cells together to know that the antibody is on that cell. Okay, so that's the purpose of this AHG reagent. All right, so here's what's happening in your DAT. You're having patient red cells, okay, so this is inside your body. Patient red cells are coated with either an IgG antibody, or it could be even complement coating those red cells. Okay. We are going to add our anti-human globulin reagent, AHG. Some of you guys, as you start working in the CLIN lab, this reagent is also referred to as Kuhn's reagent, because the scientist that discovered it, his name was Kuhn's. Okay, so it's named after the scientist. That's an old terminology, not used very often anymore. Now it's referred to as AHG, anti-human globulin reagent. And so, but just be aware, you might hear it referred to as Kuhn's. So Kuhn's reagent. All right, so after that, notice that you have your cells where the antibody was attached to your patient cells in vivo. Okay, so inside the body. Notice, remember, when that happens, we are unable to see that. So what's going to happen is your anti-human globulin reagent is kind of going to act as a bridge. Okay, notice that you have your antibody attached to the red cells, then you have your anti-human globulin that will also bind to the antibody that is attached to the red cells, bringing them, several of them close together, okay, forming that lattice formation that we will see in agglutination. Therefore, we can visualize this antigen-antibody complex. Does that make sense to everybody? So this is the purpose of your AHG reagent. It forms a bridge between the antibody that is coating the cells, and we are able to visualize the agglutination. Okay. The thing you need to know also is there's different types of reagents, and we're going to talk about this. This is a polyspecific reagent, meaning that polyspecific AHG contains both IgG and complement. Right? That's why it's called polyspecific. Okay? So if the patient cells are coated with an IgG antibody or complement, polyspecific reagent will give you a positive reaction. All right? However, using polyspecific reaction, you don't know if it's due to an IgG antibody or a complement. So then we have to use what we call monospecific reagent. In your monospecific reagent, you'll have monospecific IgG and monospecific complement, C3b, C3d. Okay? So the DAT is kind of a three-step test. And so what most blood banks will do when they're doing their DAT, they're going to start with polyspecific. If it's negative, your patient has a negative DAT, you're done. If you have a positive reaction with polyspecific, you have to take the step further and identify exactly what is coating patient cells. Okay? So you start with polyspecific, and then you're going to move to monospecific. And then let's say, and I have a chart that really demonstrates this coming up. If you have a positive reaction with polyspecific, then you're going to run your monospecific complement, you're going to run monospecific IgG. If your monospecific complement is negative and your monospecific IgG is positive, that means there's an IgG antibody coating patient cells. Okay? If your IgG monospecific is negative and your complement is positive, that means your extravascular hemolysis, cell lysis could be due to complement on the patient cells. Okay? And there are all of our ABO antibodies can activate complement because they are IgM classification. We do have only a couple IgG antibodies that are able to activate complement. All right. I mean, that's just what I mentioned. And you guys keep in mind too that hemolysis is considered a positive reaction in blood bank. I think I've mentioned that before, especially if you are doing your testing and after you centrifuge and you're grading your agglutination and you notice a very small cell button and a red tinge to your test tube, coloration of your supernatant, that indicates hemolysis. That is a positive reaction, okay? All right, you guys, we talked a little bit about complement in a previous lecture, and we have a whole lecture later on in the course dedicated to complement. But what's going to happen is once the complement cascade is activated, some cells, the whole cascade will not follow through. And you might have what we call C3b, C3d attaches to the cell membrane. Our reagent will detect that C3b, C3d. That's what we're detecting. So once complement is activated, C3b, C3d remains on some of the cell membranes, and that's what our anti-human globulin reagent is attaching to, and we can detect complement through that way. And again, typically you'll see hemolysis if it's complement involved. And it's the AHG reagent that lets us see that sensitization by complement. All right, so our Coombs reagent, or anti-human globulin, again, first discovered by Coombs in 1945, helps us in identifying IgG antibodies and or complement. There's two categories of reagents. We have the monospecific antiglobulin and we have the polyspecific. So I want you guys to understand this blood bank language. All right, so used to how this reagent was derived, they would take some urine, some type of rodent, whether it be rabbits or mice, okay, they inject them with human cells, okay. The rodent is going to build antibodies, okay, so then we can extract those antibodies in a polyclonal method. You're having multiple cells, all right, so think about your B cells, your plasma cells building those antibodies, producing multiple clones, okay, so you have multiple clones being produced, and it's polyclonal, anti-C3b, C3d, so that's your complement. You also have polyclonal IgG antibodies being extracted too. Okay, so polyclonal means that it's coming from multiple plasma cells, all right, so multiple clones are being produced of these antibodies. The thing about polyclonal is you have multiple cells producing multiple antibodies to these, and so they have a very high reaction rate. You'll hear it referred to as increased sensitivity. A lot of times in blood bank we call that cross-reactivity. So if you have some unexpected reactions and you're using a polyclonal reagent, oftentimes what people will do is they will switch to a monoclonal reagent. And the reason for that is because the monoclonal reagent is very specific to one clone of plasma cells producing the same antibody. Okay, so it's very specific to the specific antigen, to the epitope on the antigen. Okay, so it's more specific, and so you typically will not have non-specific reactions or cross-reactivity. Does that make sense to everybody? So a lot of your blood bank reagents, there are tons of vendors, Immucor, Bio-Rad, Quotient. So you always want to pay attention to what type of reagent you're using. Is it a polyclonal or is it a monoclonal? Okay. Now there's even what we call a polyclonal monoclonal blend. So sometimes they'll take both methodologies and they'll mix them together. I highly doubt you'll see anybody using this, again, because you could have some cross-reactivity, some non-specific reactions that interfere with your blood bank findings. Okay, so typically what most labs you're probably going to see now, everybody's using this monoclonal technology. Okay. And the basis behind the monoclonal technology is they use a hybridoma. They use like a multiple myeloma cell. And then they fuse them together. And so it's a specific antibody being produced. Okay. And it can be either C3B, C3D, or IgG. Okay. So keywords that you need to pick up on there: polyclonal versus monoclonal. Where is the antibody coming from? Is it from a multiple clones producing multiple antibodies? That's polyclonal. Is it from a single line of plasma cells producing the same antibody that is specific to the epitope on the antigen? Okay, so your monoclonal is more specific. Right? Does that make sense to everybody? Okay, and then polyspecific means that it contains both IgG and complement. Okay? Your monospecific is either specific for IgG or complement. Okay, so those are three different reagents. Polyspecific contains IgG and complement. There's another reagent that is monospecific, C3b, C3d, and then another reagent, monospecific, IgG. Okay. Anybody have any questions on that? That's some blood bank language that you'll hear a lot about.
When we're giving them complements, I guess they're building antibodies to complement that they recognize as not being their own?
We are not necessarily giving it to them, but we're trying to see if complement is coding their cells. So think about this is the DAT, all right? So in the direct antiglobulin test, you are testing what is directly attached to your patient red cells. So in that test tube.
Sorry, I was talking about inducing.
Oh, yeah, when you inject these with the human, yeah, you will give them complement. Human complement. Yep, and then they build the antibodies. Yeah. And that's how they get monospecific anti-C3b, C3d. It's polyclonal because it's coming from several different clones of plasma cells. All right, but it's monospecific because it's all C3b, C3d. Okay, so you guys make sure you understand that language: polyclonal versus monoclonal, polyspecific versus monospecific.
Still trying to grasp the difference between how they're formed, I guess. Is it
this might
when
help
we
you.
go?
This might help too.
It may help.
Yeah. So if you have monoclonal, all right, so you have one specific line of cells producing antibodies. That's monoclonal. Okay. Versus polyclonal, you have several different B cells transforming into plasma cells producing multiple different types of antibodies. So the thing is, you have multiple different epitopes. So it's very, it can cause cross-reactivity because of all the different epitopes can bind to the antigen. Where this is very specific. Does that help?
A little bit. I'm still a little bit less clear on like how to get one and not the other. How do we, if we're going
from the urine, from your host.
With, yeah, we're starting with our host. Yeah, I fully understand how we're getting polyclonal because that's going to be the natural response to giving it a foreign antigen. Right? I guess I'm a little less clear on the hybridoma.
Oh, okay. Here, this chart, this might help you. This one right here.
This one.
Yeah, so this is your monoclonal. Some type of rodent is used, whether it be a rabbit or a mouse. And then the antigen is injected, the human antigen. Your mouse is going to build the antibodies. Those antibodies are extracted, okay? Then they're mixed with some type of human, some type of tumor cells, usually like a multiple myeloma cell. They're fused together. And then that's what we call the hybridoma, okay? And then those are extracted. And then you have that hybridoma producing antibodies. That gives you your monoclonal antibodies. Does that help?
A little bit.
This is how your manufacturers come up with your Antisera and your AHG reagents. This is how it's all derived. I added this polyclonal versus monoclonal just so you guys can see some advantages versus disadvantages. Your polyclonal, it's very inexpensive to produce, very quick to produce. You have your higher overall antibody affinity against the antigen because it recognizes multiple epitopes, like I mentioned. That could cause some cross-reactivity. Okay, so this is polyclonal. And then it might detect some antibodies that are in low quantities. Disadvantages, variability between different batches of from your manufacturer, okay, and then higher potential for cross-reactivity. That is your huge disadvantage for polyclonal reagents. And then your monoclonal, again, it's very specific for one epitope. It can be produced in large quantities of an identical antibody. Okay, so we typically do not see that cross-reactivity. Right, so that's why a lot of clinical blood bank labs are going to the monoclonal reagent. That's what's most commonly used now. Very highly specific for a single epitope of your antigen. However, it's very expensive, more time to develop because you're using the hybridoma technology. And sometimes if you ever have a change in your epitope structure, it will render that reagent unable to detect. So that's why sometimes you might see some blood banks use a combination. Might see them use this blended polyclonal, monoclonal right here, but not a lot of people use that, all right? Monoclonal is now the choice of reagent. And that's why you have so much, as we start building on our blood bank, you will start seeing all the different reagents, and that is why now we have very specific reagent. We have the monoclonal complement, C3b, C3d. We also have the monoclonal IgG. As we start detecting specific antigens, you'll see that we have monoclonal anti-D. We have monoclonal for all of our red cell antigens, all right? And that's why. All right, any other questions? I took this chart from your textbook as well. It just kind of further differentiates monoclonal versus polyclonal. All right, so your polyspecific, keep in mind the term poly there. Polyspecific does contain, oftentimes students can't really wrap their head around this. Polyspecific does contain both anti-IgG and anti-C3b, C3d. Okay, so that's your anti-complement. So what you need to realize with this is this reagent is not detecting, remember IgM antibodies are highly capable of activating complement, okay? But this reagent's not binding to the IgM antibody, it's binding to the complement, the C3b, C3d on the red cells, okay? And so this is your reagent, polyspecific anti-human globulin reagent. Again, it could be made from a rabbit, could be made from maybe a rabbit mouse blend, some type of rodent. It's usually extracted from some type of rodent. All right, so remember I mentioned that usually if you have a positive DAT, you're starting with polyspecific. Polyspecific contains both IgG and complement. If you have an agglutination with polyspecific, that means something is coding patient cells. Then we have to take that step, test a step further, and exactly identify what's coding patient cells. Is it complement or is it IgG antibody? That's where the monospecific reagent comes in. And your monospecific can be two types, IgG or complement. So when we think about doing the DAT, really we worry about the DAT, we worry about complement in the DAT, we do not worry about complement in the IAT, okay? So in the IAT, in the indirect antiglobulin test, we're looking for any unexpected IgG antibodies. Okay, so complement is typically not a concern in the IAT. In the IAT, it's an indirect test. Another way to think about that is we're using patient plasma. Okay, so complement has been involved. It's on the patient red cells. Okay, so it's not going to be in patient plasma. All right. Detecting complement attached to patient red cells is very important in blood bank. That lets us know something has initiated complement, something going on inside that patient's body that is initiating complement, whether it be an IgM antibody or maybe one of our few IgG antibodies that can activate. That does indicate cell lysis is occurring inside that patient, okay? And then you have your monospecific anti-IgG and your monospecific C3b, C3d. I want you to understand that those are two different reagents. Monospecific IgG, monospecific anti-C3b, C3d. Okay. So positive DAT, very important in blood bank. Positive DAT means that the patient's red cells are coated with something that's going on inside that patient's body. What that could mean is maybe if you're dealing with a pregnant female, maybe mom's antibody is, or maybe you're dealing with, let's say, a baby, all right? You're doing a DAT on a newborn, and you have a positive DAT. That means where you have an antibody coating baby cells, where'd that antibody come from? Can only come from mom, all right? So that means baby has a positive DAT. They could have a low H&H. They could be in respiratory distress. Some of you guys might have heard of babies being set under the UV light or in the natural sun, usually because if there is increased cell lysis, then they might have a little bit of jaundice, right? Increased bilirubin, so they set them in the light. And we'll talk about that when we get to the baby section, why they set in the light, what that does to the bilirubin. Another example, so that's hemolytic disease of the newborn. When mom's antibody coats baby red cells, the baby goes into distress. Hemolytic disease of the newborn can be due to an ABO antibody, where mom is type O and baby is either A or B. Or it could be due to another IgG antibody, such as anti-D is the most common cause of hemolytic disease of the newborn, when mom hasn't had RhoGAM and she builds that anti-D. Transfusion reaction. Let's say you're working up a patient and the patient had previously been identified with maybe JKA, one of our kid families. JKA is notorious for having a very low titer, often so low that blood bank cannot detect it. So if you don't have any history on your patient, then you might say your patient has a negative IAT. We're going to give them a cross-match compatible unit. Maybe it's JKA positive. All right, so what's happening? Your patient has anti-JKA, your donor cells are JKA positive. Your patient's anti-JKA is going to attack those donor cells. Your spleen is going to involve in extravascular hemolysis. Your patient's going to present maybe 3 to 7 days later with symptoms of anemia and maybe a slight jaundice to the coloration of their skin. That's a delayed transfusion reaction. Okay, we see that quite a bit in blood bank because the kid family is notorious for dropping to undetectable levels. That's why patient history is so important, and that's why record keeping in blood bank. If you identify a patient with antibody, we will keep that on file forever. Okay. Autoimmune hemolytic anemia. So we've talked about this a little bit in hematology, whether it be a cold reacting antibody or a warm reacting antibody. Keyword there is autoimmune. So your patient has built some type of auto antibody attaching to the patient's cells. That will cause a definite positive DAT. Okay. And then there are some drugs that will cause the patient to have a positive DAT as well. And that's just a drug-induced anemia. So.
How do you give somebody blood products that have autoimmune hemolytic anemia?
It's very complicated. Oftentimes, if they have an autoimmune hemolytic anemia, if it's cold reacting, meaning that it's only reacting at initial spin, blood bank can recommend the use of a blood warmer to warm that unit up prior to being transfused. If it's a warm reacting antibody, typically a warm reacting antibody, we are not going to be able to give completely compatible units of blood. So what we would try to do, if we have an established phenotype on file for that patient, we can try to give antigen negative cross-matched, least incompatible cross-matched units. But with warm autoantibodies, you will hardly ever get a negative cross-match. And so if a blood bank will recommend this patient not be transfused at all. But if absolutely necessary, you can give least incompatible antigen negative. Now, whether you do a complete phenotype match, they're probably only going to do like the most common clinically significant. Maybe they'll watch their RHs, so like big C, little c, E, big E, and little e, and the Duffy's in the kids. So they'll try, and Kale, they'll try to kind of phenotype match those to make sure that we don't give them a foreign antigen and then they're going to build an antibody to it. Because the problem with warm autos is we cannot identify any underlying allo antibodies because they will react with everything. Now we have some techniques in blood bank that we'll talk about that we try to use. We'll try to absorb that warm auto out of their plasma. In my experience working with that, you could do 4 treatments. You could do 4 rounds of auto absorption. It's still there. Might have weakened a little bit, but that warm auto antibody is still there. So the best case scenario, what in an ideal world, you would have an established phenotype on them. You would give them phenotypically matched, least incompatible. But for warm autos, in my experience, you're never going to have a completely negative cross match. All right, so for transfusion reactions, so the example that we used about the JKA, notice that if your patient had anti-JKA and your donor cells are JKA positive, so here's your donor cells, your patient's anti-JKA, once exposed, right, this is an amnestic response, this is a secondary immune response, that titer, IgG, is going to go up quickly, okay, that titer is going to go up, that antibody is going to attack your donor cells, okay? And then that would cause a positive DAT, right? That's an example of a transfusion reaction. If you were to give your patient the wrong type of ABO blood, that would cause an acute hemolytic transfusion reaction, going to be immediate, involving IgM antibodies. Then you will see complement coating your patient cells as well. And you're going to have a lot of cell lysis in your tubes. You'll see hemolysis immediately. Okay, you might even have a dual population of cells picking up on some of the donors and some of the recipients. Okay. And then here's an example of hemolytic disease of the newborn. So here are your fetal red cells, and you have maternal antibody, mom's antibody, coating patient cells. Remember, in DAT, we are detecting what's coating the cells. Okay, so in this example, we would be able to pick up on this mom's antibody. And again, if baby is Rh positive, mom is Rh negative and has anti-D, then mom's anti-D will coat baby cells. And this is a very severe, this is the most severe case of hemolytic disease of the newborn when anti-D is involved. That's why we have Rogan, it's a prophylactic to prevent mom from building anti-D. Okay, this is a very serious case for hemolytic disease of the newborn when anti-D is involved. Autoimmune hemolytic anemia. If the patient has some type of autoantibody that is attaching to the red cells. Oftentimes what you'll see in autoimmune hemolytic anemia, both your complement and your IgG are both going to be positive. Okay. And then here's some drug-related mechanisms. So if you have a positive DAT due to drugs, oftentimes you don't really have not necessarily anything IgG coating the cells. You're just having the drug is cross-reacting with our reagents and it's causing cell lysis inside the patient as well. So oftentimes what's going to happen is if it's drug-induced, I don't know if I should go here yet. If you have a positive DAT with polyspecific and then you do your monospecific test, the next step is to do an elution. All right, we are going to try to break this antigen-antibody bond right here, and we're going to try to extract that antibody off the cell so we can identify it. Okay, that's an elution, and we're going to talk about an elution too. If we were to do it in a dilution on drug-induced, your elution would be completely negative. All right. Whereas if you do an elution on your hemolytic disease of the newborn, we're going to be able to identify this antibody. Probably anti-D, anti-Cal. Those are the 2 most common IgG antibodies involved in hemolytic disease of the newborn. Okay. That's a little bit further. We haven't talked about elutions yet, but that's your next step after a positive DAT. In complement, if you have a positive DAT and it's due to complement coding patient cells, and we were to do an elution, your elution would also be negative complements involved. All right? Because why is it going to be negative? If you think about, and this really ties into the IAT, think about if your mixed patient plasma or your eluate with our panel cells, which are all group O cells with a known antigenic profile, complement is not on those cells. Okay, so your complement that might be in your patient eluate or plasma will not react with our panel cells, so it's going to be all negative. Doesn't help us in identifying. So typically, if we have a positive DAT due to complement, that's really as far as we can report it. You know, we want to know why. Was the patient transfused the wrong type of blood? Is there another IgM antibody that might have been missed? That might require some further investigation. But as far as our eluate testing and our panel, it's all going to be negative. All right, so in hemolytic disease of the newborn, the DAT on the newborn will be able to detect if mom's antibody is attached to baby cells. And again, the most significant, most detrimental is if mom is Rh negative and has built anti-D and her baby is Rh positive. Okay, so her anti-D is going to coat baby cells. If it goes untreated, that could ultimately result in death of the baby. Transfusion reaction, again, if wrong type of blood is given. And we have a whole section dedicated to transfusion reaction workups. If you're ever in blood bank and the nurse calls you and says, oh, my patient's complaining of side pain, my patient spiked a fever, or she's sweating, broke out in hives, those are all symptoms of some type of transfusion reaction. Your first step, your automatic response, immediately stop that transfusion, okay? And then if they want to do a transfusion workup, which they always will, they will send that unit back to you. The number one thing we're going to check for, what's the number one error in blood bank? Clerical error. Okay, so we're going to request a post specimen. We're going to repeat all of our testing. We're going to make sure our patient's ABO matched, pre and post. We're going to make sure the unit was labeled appropriately. We want to make sure that the mistake was not clerical on blood bank side. Want to make sure patient identification was done at the patient bedside. Okay, all of this is documented, and we'll go through each step of that as we go through the course. So if you have a previous workup before the transfusion, typically we don't do a DAT on a normal basis. Okay, we only really do the DAT if it's warranted. Right, so if your DAT is always done on newborn testing, so anytime you have a newborn, you'll always do a DAT. Anytime you do your IAT and your auto control is positive. Having a positive auto control means that something is coating patient cells, causing it to react with patient plasma. Okay, so that will warrant a DAT. It's not like our ABO, RH, and our IAT that's done standard routine on every patient in blood bank. The DAT is not done on a routine basis, only if there is a issue that needs to be investigated. Okay. So what I was going to say about transfusion reactions is if you had a previous sample before the transfusion, then and your DAT was negative, then they're transfused and their DAT is positive. That indicates that an antibody is now coating patient cells. Is it due to our anti-JKA or JKB? Is it due to the wrong ABO being transfused? That indicates a transfusion reaction did occur. Okay. And this just explains the anti-JKA scenario I gave you. The KID family is notorious for that. Certain antibodies not detected originally in the patient plasma, then they were transfused, amnestic response, that titer is going to jump way up, and then we'll be able to detect it and we can identify it. So what do you think would happen for future transfusions for that patient? If they have blood stored, they most certainly could. We do have autologous donations. That's possible. Otherwise, we could, what we call antigen type, we could give them antigen negative donor units for whatever antibody was identified, right? That way, their patient's antibody won't attack the donor cells. Okay? And then the autoimmune hemolytic anemia is another one. I mean, you guys remember this from blood bank when we talked about hereditary hematology, we talked about hereditary spherocytosis versus autoimmune hemolytic anemia. What's happening in autoimmune hemolytic anemia is that antibody is attaching to patient red cells. The spleen is either culling or pitting those cells. So if it's pitting, then it's causing the formation of spherocytes. All right, so in autoimmune hemolytic anemia, we'll see spherocytes on the patient peripheral smear, which looks just like hereditary spherocytosis. And if you guys remember from hematology, the DAT was the test to differentiate hereditary spherocytosis from autoimmune hemolytic anemia. In hereditary spherocytosis, remember spherocytes is due to a defective protein structure in the patient's cells. It's a hereditary condition. All right, so the patient's not going to have a positive DAT in hereditary spherocytosis because those spherocytes are occurring because of the protein defect. Versus autoimmune hemolytic anemia, the spherocytes are occurring as the cells pass through the spleen, okay? And that pitting process is occurring. So autoimmune hemolytic anemia, positive DAT, all right? As we go through this course, we're going to talk about drug-induced positive DATs. We'll talk about some specific ones. Aldamate is a known drug that will cause a positive DAT. It's used to treat high blood pressure. Quinacrine is another one that is known to cause a positive DAT. I think it's used, and there's another one, it's used to treat heart arrhythmia. It's known to cause a positive DAT as well. All right, so I like this schematic from your textbook. Really lets you know what's going on inside the tube of the DAT. All right, so remember, it's the direct antiglobulin test. So we are using patient cells. We're trying to detect what's coding patient cells that occurred inside the body. Okay, we're not inducing that. We're not doing that in vitro. This is in vivo. Okay, so patient red cells, some type of antibody coding patient cells. All right. If it's IgG, remember, IgG is a very small molecule, has a very hard time bringing all the cells together so we can visualize agglutination. So the antibody has sensitized the cells. We're going to add our anti-human globulin, all right? It kind of forms a bridge. And so it will bind to the FC portion, see how it binds here, all right, of the patient antibody, okay? And it's going to bring all the cells together, forming agglutination. So then we know an antibody is coding patient cells or complement. Okay, that's your DAT. All right, so your DAT procedure, you're going to take your patient cells. You're going to do a series of 4 washes. Right, and the reason we want to make sure that we get a really good wash is we want to remove any unbound protein. And the reason that is so important, that unbound protein can neutralize your AHG reagent. I mean, what that means is it reduces the reagent's ability for binding, okay? So if you have improper washing, this is very important. If you have improper washing, it could cause false negatives. Okay, because improper washing removes the protein. If you have excess protein and it neutralizes your AHG reagent might not bind. Okay, that could cause false negatives. All right, so you're going to wash your patient cells. Most blood bank labs will have a series of 4 washes. That's the standard. And you can do this manually. You guys will all get to wash cells manually. And then you'll get to use the cell washers. The cell washers are instruments that add saline, centrifuge, decant for you. All right, you will have a high appreciation for the cell washers after you do manual washing. Okay. And then after you wash, you're going to add your polyspecific AHG to the tube, and then you're going to centrifuge and read for agglutination. All right, so then if it's positive with polyspecific, you're going to do the same thing using monospecific IgG and monospecific C3b, C3d. And then here's a chart for some interpretations, okay? So if your patient red cells are sensitized with IgG only, you'll have a positive reaction with your polyspecific, of course. You'll have a positive reaction with your monospecific IgG, but a negative reaction with your monospecific C3b, C3d. If your patient has been sensitized with both IgG and complement, positive reaction with polyspecific, positive reaction with monospecific IgG, positive reaction with monospecific C3b, C3d, okay? And then if it's only complement, you'll have a positive reaction with polyspecific. So all three of these scenarios have a positive reaction with polyspecific. Negative with monospecific IgG, but positive with monospecific C3b, C3d, okay? All right, so our preferred sample, we want to use the EDTA. That's just because it will chelate calcium. If you guys remember from immunology, you studied the activation of complement. Calcium is needed for the activation of complement. So we do not want calcium to activate the complement cascade in vitro, okay? We are trying to detect if it has already been activated in the patient's body. And so that's why for the DAT, EDTA is so important. You'll primarily probably see EDTA and blood bank testing across the boards. However, you might receive a serum tube every once in a while. Blood bank tests can be done on it, but EDTA, except your DAT, don't do it on the red top. But our preferred tube is the EDTA. Again, and that's just because we want to detect that complement in vivo. We don't want to initiate the activation of that complement, okay? All right, so we also have what we call check cells. There's two things you need to understand about using the anti-human globulin reagent. Number one, whenever you add anti-human globulin reagent, you will look for agglutination macroscopically to your eye. You also, if it's negative to your eye, you have to confirm it under the microscope, okay? Remember when I said our ABO interpretations, we don't ever look at it under the microscope? Anytime you use AHG, if it's negative to your eye, you will look for microscopic agglutination. You're going to put that tube under the microscope and look for small agglutinates, okay? Remember when we were grading, talking about our grading reactions, and you had the plus sign with the circle around it? That indicates a microscopically positive reaction, okay? Anytime you use AHG, you have to look at it under the microscope, okay? The second thing is, if you have a negative AHG2, it's macroscopically negative and microscopically negative. You must confirm that negative with what we call check cells. Check cells are group O cells. They are coated with anti-D. So that's an IgG antibody. So you can think about them as IgG coated cells. What's in our anti-human globulin reagent? So IgG. So you have IgG in our anti-human globulin reagent, okay? If that anti-human globulin reagent is negative, you're saying there's no antibody coating patient cells, all of that AHG reagent remains unbound. It's free in that tube. If we add IgG coated cells and we centrifuge and read for agglutination, what should your result be? You should have agglutination. All right, so the purpose of check cells, it confirms all AHG negative tubes. And the reason for that, that ensures your proper washing, right? So let's say if your AHG reagent has been neutralized, it did not agglutinate with your patient cells, it will not agglutinate with check cells, that invalidates your test, okay? So anytime you have a negative reaction after adding check cells, that invalidates your test, you have to repeat it all over again, okay, that usually indicates improper washing, excess protein present in your test tube. Does that make sense to everybody? All right, so I have a disclaimer, and this always throws students off. Check cells is going to make your negative reaction go positive. That positive reaction does not reflect your patient testing. That's just kind of like a built-in internal control, okay? So if you have a negative AHG at microscopic and microscopic, your result for your patient is negative. So don't read your check cell result as positive. And don't think, you know, if you're doing a DAT and then your test goes positive after check cells, don't report that DAT as positive for your patient. Your check cells is just an internal control for us to let us know that the test was performed appropriate washing was performed. There is no antibody or complement attached to patient cells, and that's why our AHG reagent did not agglutinate. Okay, does that make sense to everybody? All right, you guys will see this in lab. You'll get plenty of experience. Not today in lab, but next week we're going to start adding in the AHG and check cells. Okay, so you guys will get practice with this. Okay, so what if you have done your DAT procedure, it's positive, what's our next step? We have to do an elution, okay? And so there's various treatments that we can do. You're using patient cells in this elution, in this procedure. It does use quite a bit. You're gonna use like a mill of patient cells. And you're usually gonna heat treat them, you're gonna acid treat them. And what we're trying to do in this elution, there's an antibody or complement coating patient cells, correct? We want to break that antigen antibody complex. We're going to disassociate the antibody from your patient cells. Okay, and we can do that through heat treatments. There's one specific one if you're dealing with moms and babies, and mom is type O and baby is either A or B, and we want to find out exactly what's coating baby cells. We can do what we call a Louis freeze. So we're going to take some of baby cells, we're going to put them in the freezer. Does anybody know what happens to cells when exposed to extreme temperatures, whether you heat them or cool them down? They're going to lyse. Okay, what happens to the antibody that's bound to those cells after cell lysing? It's now free in your supernatant, all right? So we can test that supernatant and we can identify the antibody that was coating baby cells, right? That's an example of Louis freeze. Usually heat treatment is only done if you expect some type of ABO discrepancy, okay? We typically, if you're dealing with another IgG antibody, we will do an acid eluate, all right? So you do a series of treatments. That acid is going to affect the pH. It's going to dissociate the antibody from the red cell membrane, and then you go through a series of washes and you're left with your elution or your eluate, the supernatant. That's where your unbound antibody that was attached to your patient cells is now, and we can run it against our panel cells for antibody identification, okay? Very helpful in moms and babies if it's due to another IgG antibody or a transfusion reaction. Those are two instances where the eluate might identify the antibody, okay? So this I took this from your textbook, just let you know what's happened here. So here's your patient cells, right? They have been sensitized, some type of antibody coating them, positive DAT with polyspecific IgG and monospecific IgG. Okay, so we perform our elution, we do an acid treatment on them, pull off the antibody that was coating cells. So now, once you do an elution, the cells are no longer good, all right? Usually they're lysed, okay? So you cannot use patient cells. We're only testing the supernatant, where your unbound antibody is now. Okay, so you run your eluate, your supernatant against known antigenic profile, okay? And this is what your panel looks like. You guys haven't seen a panel yet. Usually you have an 11 cell panel, some even have a 16 cell panel. These cells all have a known antigenic profile, and then so you can write your reactions over here in the initial span 37 and AHG phase of testing, okay? And then we have a procedure that we call ruling out, and then you can rule out and see what your patient reactions match the pattern of reactivity, what antigen is present on each of these cells to cause a positive reaction. All right, so that's the DAT. Your takeaways, number one, your DAT is used to detect antibody or complement that has attached to patient red cells in vivo. Okay, it has happened in the body. And the reagent used for the DAT is your anti-human globulin. Okay. Most oftentimes when you're going to see a DAT performed, anytime you're doing newborn testing, mom and baby, we will always do a DAT on the baby. That lets us know if the maternal antibody is coating baby cells. Anytime a transfusion reaction is suspected, we will always do a pre-specimen. All right, so we want to pull that specimen from the pre-transfusion. We'll do a DAT on it, and we'll do a DAT on the post-specimen. Okay, you're also going to repeat all your testing just for a clerical error check. Autoimmune hemolytic anemia, that will cause a positive DAT, and drug-induced reactions can cause a positive DAT. Most labs are going to start with polyspecific. If you're positive with polyspecific, then you'll carry through with your monospecific testing. All right, does anybody have any questions? Okay. Sarah asks, so can you have polyspecific with monoclonal antibodies? Yes. Okay, so are you thinking about your polyspecific reagent? So you could have a polyspecific reagent, meaning that you have monoclonal blends of both IgG and complement. Yes, you can have that.